Okay, we're up live. Okay, stand by, Dr. Betty.
Okay.
Okay, stand by in 5 seconds. 4, 3, 2, 1. On you.
Okay. Good evening, everyone. Mashita, do you mind taking off the slide for a while?
Okay, so just gonna stop sharing.
Yes.
Okay.
Okay. Good evening, everyone. Welcome back to another session of Beating Hearts webinar. I'm Dr. Betty Tay, and we have this is our first webinar for 2025, and we have here with me Dr. Siti Nur Masyithah, who's a consultant urologist. Now, it's a very rare species, a consultant urologist who is a woman. So maybe you'd like to introduce yourself a little bit, because Dr. Masyithah and I just made acquaintance today itself, other than on WhatsApp. Maybe you can tell us more about yourself.
Okay, hi, Assalamualaikum. Good evening, everyone. I'm Masyithah. I'm a consultant urologist. Like what Dr. Betty has mentioned, this is a rare species, but it's not going to be extinct soon because on the way, there are many more new female urologists are coming up. So I am a MBBS grad from University Malaya. I did my urology training in Malaysia. I also further studies in Japan, attachment of urogyne. I had my fellowship in Bristol, UK, for functional urology, female urology, and also endourology. I was in all the way till about October 2022. I left and I'm currently working as a consultant urologist, a resident in Damansara Medical Center, and visiting in KPJ Klang Specialist Hospital. So I'm very happy, very glad to be here with everyone. Such a big crowd over here. I think there's about 99 of us. And
Yes.
thank you so much, Dr. Betty, for contacting me on WhatsApp through LinkedIn. And I hope this will be a fruitful webinar for everyone.
I'm
Thank you
sure
for
it will.
attending. Yes.
Okay, come. We start first.
Okay, let me just share my slides again. Okay, let's see. All right. Can you see my slides?
Yes, beautiful.
Okay, sure. So the topic for today is very interesting. Common urology problems in women. I'm sure each and every one of us have female patient, especially ladies coming to you with urinary tract problem, not sure who to refer them to. Do you refer them to the urogynecologist or you refer them to the urologist? And like what Dr. Betty has mentioned, majority of urologists in Malaysia are men, and some women, they're not really that comfortable to talk about the nether region to the men. So it's all right. I'm sure each and every one of us can assist them one way or another. I will start off with a brief overview of all the diseases related to urology in women. You can manage them on, a few simple investigation, treatment. If that doesn't work, then you can always refer them to a urologist. And of course, I'm always happy to see any patient that have a urology problem that require intensive investigation and further treatment after failed treatment from or treatment that doesn't really work from my other colleague. Okay, so for today we will talk about a few interesting topic. There's a lot to cover, but since I only have an hour, so I'm going to concentrate on hematuria, urinary incontinence, and urinary tract infection. So we're going to start with hematuria. So, commonly I see patient in my clinic, they were to attend health screening. They were to come to me and said, look, I was informed by my doctor at the health screening center that I have hematuria. I have blood in my urine, but I do not see any red color urine. So it's important for us to inform patient, to tell them that hematuria can also be microscopic. If they do not have a medical background, to them, no, not red color, no blood. But you need to explain to them that microscopic hematuria can exist, and different gradients of hematuria, like we can see over there in the picture, 0.25%, 1%, 5%. Even if it's microscopic, it is something important, and further investigation needs to be done. On top of that, the next thing that we need to ask patient is that, was it painful or was it painless? Most people have this perception that if it's painless, it's all right. You can just ignore it because it doesn't, disturb any of your daily activities. But actually, painless hematuria is more dangerous than painful hematuria. And on top of that, if it's painful, patient will run to the hospital or they will run to see a GP. And most of the time, treatment can be given promptly. So if you have hematuria, bleeding can actually occur from the kidney, from the ureter, or from the bladder. So, even from the urethra itself. So it's very important for us to understand this so that we will investigate further. So as we can see, first thing first, you confirm the urine test again, send for urinalysis. If you think this is related to kidney, for example, there's proteinuria in the urine test, or there is glucose in the urine test, you may want to do fasting blood sugar, may want to do renal profile at the same time. And from there, you decide whether you need to do an ultrasound or you need to do a CT scan. And be looking at the guidelines, cystoscopy is also included. I'm going to go through in one by one. So if a patient presents to you with painful hematuria, most of the time, it can be microscopic or gross hematuria. The commonest reason, especially in women, can be UTI, or in serious cases is also known as cystitis. So what happens is that, as we know, female have shorter urethra compared to men. So the infection is from outside to inside, and this can actually cause problem to the ladies. And in severe cases, if it's not treated early, they can come with pyelonephritis when the infection has traveled all the way up, and they have thickened bladder, so on and so forth. So if this is the commonest problem, treat the UTI first, repeat the urinalysis maybe about 2 weeks or so. I usually give them antibiotics for 1 week. I repeat the urinalysis for about 2 to 4 weeks. Most of the time, you can see decrease of red blood cell or the red blood cell disappear in the urine test. Next, if you think that this is more than just UTI, especially if they have gross hematuria or they have flank pain, then you might want to do a CT renal four-phase. So I have a few images here of some patients that I've seen throughout my clinical practice. We have right kidney cancer on the top side here. As you can see, there's a mass in the kidney. Patients like this usually present with painless hematuria, unfortunately. It may be an incidental finding when they were to go for health screening, because health screening, usually they were to do ultrasound. Ultrasound will mention things like there is a lesion in the kidney. So for the evaluation, we will proceed with CT renal four-phase. Well, you can always do CT abdomen pelvis. It's not to say it's wrong, but it's a bit too much because we are concerned about the urinary tract. CT renal four-phase is a better option. Second one is a stone in the ureter. So if someone presents like this, most of the time it is painful, and not just painful from the stone, it can also be due to the hydronephrosis that we have over here, because the capsule of the kidney has been stretched. So cases like this will need immediate unblocking of the kidney, or kidney failure will occur because you can see part of the cortex is thinning out slowly. And the last one is the urinary bladder cancer. As you can see mass in the bladder, and because this mass is massive, it has also caused bilateral hydronephrosis. In all three cases, most of the time they would present with hematuria, and in cases of cancer, unfortunately, it is always painless hematuria, except that it has metastasized to the bone, to the liver, then patient will have painful hematuria. Okay, so cystoscopy. If you were to look at the guideline, I usually tell my patient, if you have hematuria, either visible or not visible, 3 basic things. First, you may have UTI. If we have treated the UTI, it is still there, the red blood cell is still there, it might be stone. So if you want to look out for stone, you can do ultrasound KUB, ultrasound kidney ureter bladder, or you can also do a CTU, CT urography, CT urogram without contrast, because that will be adequate to look at the stones. Well, you can do X-ray, but not all stones are visible on X-ray. For example, uric acid stone is radiolucent, so you won't see it well on an X-ray KUB. So if you have excluded stone, so the last bit is the cancer bit. Cancer can occur in the kidney, it can occur in the ureter, it can also happen in the bladder. So even if you were to do CT renal four-phase, please keep in mind that you may miss bladder cancer. This is because bladder cancer usually starts very tiny, very small, 5 millimeters, so on, and it gradually gets bigger. So by the time you were to see it in scan, either ultrasound or CT renal four phase, it is a bit too late. So how do you investigate early bladder cancer? You send the patient for cystoscopy, which is basically putting in a camera into the bladder. It can be done as a daycare procedure, under local, under general anesthesia, depending on the setting. But, if you have done a scan, you noted that there is something in the bladder and you will end up with biopsy. Of course, doing it under general anesthesia will be a better option. So you can tell your patient, it may be UTI. I treat the UTI first. If that doesn't go away, we'll rub stones. Then finally, is the bladder, is the cancer part. Cancer in kidney and in the ureter will be visible on the CT renal four phase anyway. So cystoscopy will be done at the same time when you were to do biopsy for the ureter cancer, if there is any ureter lesion on the CT scan. All right, so that's the first part of the topic. The second one is UTI, very commonly seen in ladies. And most of us, I'm sure, all the audience, if you're a lady, you have experienced UTI at least once in your lifetime. You know that it's excruciating. You want to pee, but the pee doesn't come out. So, it disturbs you the whole day. Yeah, it's terrible. And sometimes you just feel like it's actually burning and there's like a big cut down there. So UTI. So it happens when the bacteria from outside, either the skin or the rectum, enter the urethra, and you have over here, it started off with urethritis. You have the burning sensation. You have the cystitis, which is the bladder is inflamed. If you were to put a cystoscopy during cystitis, everything will be looking angry, looking like the picture that we had earlier on over here. All right, so this is a normal bladder, the pinky color side, whereas the red one is the cystitis, and you have the bladder stones down there. All right, we have the urethritis, and if it's still not treated, patient usually present with pyelonephritis. So in UTI like this, it's not necessary for the patient to have stone or any growth in the urinary tract. Sometimes it is just delayed treatment for UTI. Patient may have pyelonephritis, and if they're not treated at a timely manner, they might develop abscess or pyonephrosis. Okay, so how do they present? I'm sure each and every one of you have seen patients with UTI. They complain to you lower abdominal pain, is painful to pass urine. There might be blood in the urine, which they can see. They were to tell you, I woke up this morning and I look at the toilet bowl, everything was just red in color. And then, they also complain that they need to rush to the toilet, urgency. They may have loin pain if it has progressed to pyelonephritis, frequency, daytime, nighttime, or you have the frequency, but nothing much is coming out. Maybe just drops of urine coming out. Not treated, you may get fever. And as you can see, cloudy urine, chills, rigor, feeling of incomplete voiding, foul-smelling urine. And in elderly ladies or even men, they may present to the hospital with drop in GCS. You may think that they have stroke. When you do a CT brain, there's nothing wrong with the brain, but on further investigation, you may note that they have UTI or urosepsis, which is a very common presentation. Of course, first and foremost, you need to rule out the more dangerous one, which is stroke. So if there's nothing wrong with the CT brain, next check the urine. If it's purely UTI, put in a catheter, you may see pus in the urine bag, treat the UTI, and miraculously after 24 to 48 hours, they'll be wide awake with GCS 15. We have seen that many, many times in a hospital setting. And, thankful that, this kind of patient are brought early, because as we know, elderly, their reserve is not so much. So if it's delayed, then things will de-escalate very, very fast. Okay, first thing first, if you suspect that patient has UTI, is a urinalysis. And if this is a recurrent UTI, I always advise my colleague, my friends, to do urine culture. This is because, a patient might be given antibiotic, which is not suitable. Then they were to come back again with another round of UTI. And on top of that, certain bacteria that grow in the urine may be related to certain disease. For example, Proteus mirabilis is closely related to stones in the urinary tract. Common ones are like E. coli, Klebsiella. So those are very common. It's about 70 to 60% of UTI have E. coli or Klebsiella. So it's helpful. And on top of that, I've seen many patients, they were to come to me and say, I was given white tablets or certain types of tablet, but there's no name to it. So it's very difficult for us to actually decide what antibiotics will be given next. So it's good that we educate our patient, tell them, if you were to go and see a doctor, bring the name of the medicine together so that the doctor who sees you again knows that the previous antibiotics did not work. So they need something else or, something stronger. Okay, commonly UTI over here, we treat with antibiotics, adequate antibiotics, 5 to 7 days. If patient comes back again with UTI, after the first round of antibiotics, I usually, straight away do a urine culture. If you don't want to do it on the first time, it's all right if it's not that severe, but preferably do it on the first time that you see the patient. And I usually repeat the urine culture after 2 weeks to make sure that all the bacteria has been eradicated and patient has been fully treated. Okay, so we have a bit of a classification of UTI. We have uncomplicated UTI. So what is uncomplicated UTI? It is only limited to non-pregnant women. So it can be acute, sporadic, recurrent, non-complicated, all right? So if you have a lady who is not pregnant and, there's no relevant anatomical or functional abnormality, she can empty her bladder well on normal days, she's not diabetic, she's not immunocompromised, then that's considered as an uncomplicated UTI. Complicated, all UTIs which are not defined as uncomplicated. So this goes to, pregnant women, those have, anatomical variation, for example, duplex system, or they have a diverticular in the bladder. At the same time, elderly ladies with indwelling catheters, those with renal disease, those who are immunocompromised, maybe cancer patient, diabetic patients. So those are complicated UTIs. Okay, so what is recurrent UTI? So the definition given by EAU, European Urological Association, recurrent UTI are UTI that happen, it can be uncomplicated or complicated, is 3 times within a year or twice within the span of 6 months. So in this kind of patient, it can be just UTI or together with cystitis and pyelonephritis. So cases of recurrent UTI need further investigation. You may want to do ultrasound to make sure that there's no stone. If you think that patient has something to do with anatomy abnormality, for example, urethrosil or duplex or horseshoe kidney, you may want to do a CT IVU or a CT renal four-phase to look at the urinary tract. Or if you think that, patient has some kind of spine problem, neurological deficit, they are unable to empty their bladder, things like uroflowmetry will be performed by the urologist because you want to see if the patient has high residual urine, which may predispose them to recurrent urinary tract infection. And of course, the common things that we see in the elderly or those who have spine problem, neurological problem are catheter-associated UTI. Is usually when catheter is placed within the first 48 hours. And if all these UTI are not treated, it can be life-threatening urosepsis. As you know, urosepsis, the BP tends to come down, the patient will be very sick, and normal antibiotics orally might not work very well. They need to be admitted for intravenous antibiotics. And urosepsis, blood culture, urine culture is something which is mandatory for us to know that we are treating the patient accordingly. Okay, we have something called ABU, asymptomatic bacteria in adults, because I do get some patient coming to me referred by my colleague, or when it comes to you, they do have bacterial growth more than 10 to the power of 5, but they have no urinary tract symptoms. It is not mandatory to further investigate like cystoscopy or imaging because they are asymptomatic. I do not treat urine results. I treat the patient. If the patient does not have any urinary tract infection symptoms, I will just monitor the patient accordingly. And we just make sure that you tell the patient You are asymptomatic, you are well, your white blood cell is not raised, your renal profile is normal, you don't have any fever, so I'm just going to monitor your urine result. And as mentioned down below, proteus mirabilis is related to stone. All right, so as you can see over here, when you talk about ABU, we have premenopausal females, you have elderly ladies, you have patients with diabetes, pregnant women, and the percentage tends to go higher with those of having spinal cord injuries. So in this patient, if they're not symptomatic, I wouldn't want to treat the patient. And as for pregnant ladies, if you have pregnant ladies coming to you with UTI, first thing first, please remember not all antibiotics are safe for pregnant ladies. If you're not sure, either look up in MIMS or you can consult your ONG colleague, because I do sometimes see ladies who are pregnant and they're given all sorts of antibiotics, maybe because we forgot about it or we didn't ask about it because maybe they presented at early pregnancy and they themselves are not sure whether they're pregnant or not. So it's good for us to actually ask patient, are you okay? Are you pregnant? If you're not sure, you can always do a UPT test because you don't want to give them antibiotics that may cause problem to the pregnancy along the way. All right. So management of ABU over here. So do not screen or treat asymptomatic bacteria, which is a strong rating. This is based on the EAU 2024. All right, so and as we can see over here, what is an uncomplicated cystitis? So uncomplicated is limited to non-pregnant women. Again, when you have the word uncomplicated, it's always non-pregnant women. So recommendation to diagnose, it is a strong recommendation. So something might not be right. You focus on the lower urinary tract symptoms, the dysuria, the frequency, the urgency. And then when you were to do the ultrasound, sometimes you were to see thickened bladder wall. And what I usually do for this kind of patient, I were to give them antibiotics, do a urine culture, make sure that, the UTI or the cystitis is treated fully, come back with the repeat culture showing that there's no more bacteria growing. And I will repeat the bladder ultrasound to see whether the thickening is still there. If the thickening is still there, especially only on certain area, not a general thickening of the bladder, I may advise patient to do cystoscopy because you may not just looking at a simple cystitis. This might be an early sign of bladder cancer, especially if she is high risk. High risk being that, she had cancer at a different part of the body, or she is a heavy smoker, or strong family history of malignancy. Then you may want to look more beyond just uncomplicated cystitis. Okay, over here. So they said do not use aminoampicillin, fluoroquinolone. So that's a strong recommendation for uncomplicated cystitis. All right. Okay, recurrent UTI. We have gone through this earlier. Diagnosis should be confirmed by urine culture and extensive routine workup, including cystoscopy, imaging. Again, not routinely done. We will do it if we think it's necessary. If you suspect something is not right, and you want to look further into the patient's anatomy, then you will proceed. But, again, if you were to talk to the patient and they're concerned that something is not right, same goes to you. You may think that they have cystitis which need more than just antibiotics. For example, they may need intravesical treatment. Then it's good for you to do cystoscopy, do a biopsy, make sure it's not carcinoma in situ, because recurrent UTI can be early sign of pending bladder cancer. So you don't want to miss something like that. All right, so we have over here renal calculi, outflow obstruction, if they have any urethral stricture. So urethral stricture is very common in elderly lady, postmenopausal, because the area down there is dry because after the menopause episode. On top of that is if patient had radiotherapy before, for example, they had contracted bladder, they may also have urethral stricture, and this will predispose them to recurrent UTI. So if you see a patient, ask them about their past medical history. They may have previous catheterization where predispose them to urethral stricture, or they're menopausal for a long period of time, or they had hysterectomy at a very young age. So it's important for you to look beyond just normal UTI if patient were to come to you with recurrent UTI. Okay, age related. So young and premenopausal sexual intercourse. So what I usually tell my patient is that before sexual intercourse, after sexual intercourse, pass urine, clean yourself before you go to bed. So we have something that we call honeymoon cystitis. For those newlywed, they were to tell me and said, doctor, I've been getting UTI quite frequent over the last 6 months. And on further questioning, I just got married over the last 6 months. So after the wedding, I tend to get UTI quite frequently. Then we know it's sexually related, so you advise her accordingly, and most of the time they're okay with it. But I do see some ladies who need prophylactic antibiotics when they were to have sexual intercourse. After the sexual intercourse, they need to take antibiotics, because if they don't overnight, the next day they will have they will have UTI.
Every
Yeah.
time.
Yes, I do see those patients coming to me. It's very sad because, it's a big thing. Like, because one time she was traveling with her husband to Bangkok. She forgot to bring antibiotics and she's down with UTI the next day. So she said the whole trip was miserable because, in a foreign land for you to get antibiotics is not as easy as getting it here in Malaysia. So we do have small group of
God.
unfortunate ladies who have sexual intercourse and they get UTI the next day. Some might be related to the condoms, some might be related to the secretion, so it's very difficult to really pinpoint what is not right in this group of ladies. They have gone to see the gynae colleague, no vaginal swab has been done, nothing has been highlighted that needs, there's no infection in the vagina, but every time they have sexual intercourse, they were to come to me because of UTI. So, spermicide is also another thing. New sexual partner, well, it might be because things like this can also happen. Well, not really about the mother with history of UTI. I don't see this very often, even though it's being mentioned in the guideline. Not sure about the rest of you here. And then history of UTI during childhood usually is an anatomical problem. I have patient coming back. She told me when she was in the younger days, when she was in her teens, she tends to get UTI very often, and then it disappeared for a bit of a time. Then it came back, and true enough, she actually had she actually has horseshoe kidney, which was never being diagnosed. Things like that is a congenital thing. There's nothing much you can do, but she can take precaution, drink enough water, come back for screening, making sure that she doesn't develop stones. And, if she have early signs of UTI, she will need to come back. Blood group antigen, I have not seen this. Not sure about those of you here with us today. Postmenopausal UTI, if they tend to get it very often before, they tend to get it very often after. Urinary incontinence is because of the urine leak. Because of that, they tend to get UTI. Atrophic vaginitis due to estrogen deficiency. Primarine cream will help. Cystocele, a group of prolapse, they have increased post-void urine, which usually happens in chronic diabetes. They have the ability for the bladder to fully contract to push the urine out. So every time they pee, for example, they have about 300 in the bladder, they only pee about maybe 100 or half of it. So half of it is still left in the bladder, and over time, this can cause place for the bacteria to grow because they do not flush everything out. Catheterization is also another thing. All right. So diagnosis for UTI, recurrent. So I don't really do extensive workup if they are younger than 40 years old and they have no further risk. Premenopausal, it might, you try to treat them first with Primarine cream, advise them, if they have incontinence, treat the incontinence, and most of the time they get better. As mentioned here, strong recommendation, vaginal estrogen. So I spoken to my gynae, urogynae colleague. They said for the first month, they were to, put it into the vagina daily, 0.5 gram Primarine cream. The second month, they can do it alternate nights. The third month, it can be twice in a week. And after that, it's just maintenance once a week or maybe once in 2 weeks, and see how they go about it. Most of the time, they get better when the dryness is less and, the mucosa down there is less sensitive. Okay, complicated UTI, this is on diabetic patient, immunosuppression patient, or someone with obstruction, dysfunctional voiding, they can't pee, or patient with hospitalization, they tend to get a UTI. So this is more of a hospital setting. It can happen to ladies, it can happen to men. So we need to look into this if patient were to come back again and again with fever, which we are not sure where is it coming from. Common factors, obstruction, foreign body like catheter, incomplete voiding, they may have reflux, isolated ESBL because of sepsis, recent history of instrumentalization. They may have catheter inserted, they may have a urology procedure, they may have a gynae procedure. Pregnancy is also complicated because, it can cause premature delivery in most cases if it's not treated early. Okay, so we have it over here. Okay, urosepsis is an urgent hospitalization because, as you know, if you do not treat early, patient will just deteriorate even further. So they need urgent hospitalization, intravenous antibiotics, and all the further workup as we think necessary for the patient. All right, next topic, urinary incontinence, the last bit for tonight. Okay, I do see a huge number of incontinence ladies coming to me. So most of them were to tell me that, my mom has it, my sister has it, so I guess I'm okay. So maybe it's an aging process. No one is interested to treat us. So I've been on pads or on liners for a significant period of time. But, I hope things can be better. I hope you can offer me treatment because, some of these ladies are still very active. They travel abroad, they want to, to visit places, but because they have urinary incontinence or overactive bladder, which is difficult to manage, they tend to have poor quality of life. Urinary incontinence is not it won't cause death in a way, but it reduces the quality of life, especially in active ladies. So for us, it's important for us to spend some time in those patients mentioning to you about incontinence. The first thing first, you need to know what type of urinary incontinence. I've narrowed it down to a few common ones. We have stress, we have urge, we have mixed, we have temporary. It's important to know the type because different type of urinary incontinence have different ways of management. If you mismanage this patient, they will not get better and they will suffer even longer. Okay, so first thing first, stress urinary incontinence. This is when they cough, they laugh, they sneeze. It's not stress because of the spouse, it's more of the overall thing. All right, because when I tell the patient, you have stress incontinence, say, yeah, my husband, blah, blah. So no, it's not related to your spouse, unfortunately. I understand that that's a huge stress factor, but we are talking about when you cough, when you laugh, you carry something heavy, you tend to leak urine. Stress incontinence or urinary incontinence in general, not necessary that you need to empty the whole bladder. Even droplets is still considered incontinence. It shouldn't happen, except it's very, very sporadic. For example, during the COVID time, we tend to cough a bit more and you cough really hard, then you may have one drop of urine then, but it happens very rarely, then that's okay. But we do have patients where, even a simple movement, exercising, brisk walking, they tend to, have leaking urine, involuntary leak of urine. So, it's not something that is very nice for the patient. Okay, when we talk about urge, is when you have the desire to pass urine, but you cannot wait. For example, you are watching television, you're watching your K-drama, and it is at the peak of the drama, then you suddenly feel that, oh, I need to go to the toilet. If you were to hold any longer, you know that you're going to wet yourself. That is urge urinary incontinence, or example, you are in a shopping complex, you are in pavilion, for example, looking at some clothings in the nice clothings around in Parkson, then, because of the aircon, you feel that you want to pass urine. In normal person, you are able to hold on to your bladder to go to the toilet, queue at the toilet, undress yourself and pass urine. But for those who have urge urinary incontinence, unfortunately, the moment they have the urge to pee, they tend to leak themselves. So it can be very embarrassing because I have patient coming to me and said, I was pushing the lotus cart to my car, and suddenly I feel the urge to pee. I wet myself in the parking lot. Everyone was looking at me, so I was so embarrassed, and I don't know how to walk towards my car when I'm actually dripping wet. So that is very, very sad for her, very humiliating for most patients. So if we can reduce her burden, make things better for her so that she can enjoy normal daily life, she'll be very thankful to you. So stress, when you cough, when you exert yourself. Urge is when you have the urge, you are able to get to the toilet on time. And for ladies, it is also very common for them to have mixed urinary incontinence, which is the combo of the two, stress and also urge. Stress urinary incontinence is usually because the pelvic floor muscle is not as strong as before because of aging. We went through pregnancy, we went through delivery. So the support for the bladder is not as good as before. And as we know, most of us tend to put on weight when we age because of the metabolism, because sedentary lifestyle, then that can also cause a stress urinary incontinence. For urge urinary incontinence is the problem with the bladder. It is a naughty bladder. So in this kind of patient, they tend to have overactive symptoms, which is, they have urgency, they have frequency. So as for temporary urinary tract incontinence is related to the UTI, and you treat the UTI, the incontinence go away, or they have the bladder stone and you remove the bladder stone, things get better for them. Risk factor for incontinence, us being women, elderly, ladies, obesity, I mentioned earlier, because you have the fat pad mainly at the lower abdomen, which sits on the bladder. I do have a patient coming to me and said, I was doing diet, I lost 5 kilos, my incontinence got better. And then after that, I start eating again because it's end of the year. Then now I have my incontinence again. So I said, look, you know that you were better when you lost 5 kilos. So that is the only thing that you need to do rather than coming for medicine. Smoking is another thing. Poorly controlled diabetes, chronic cough, treat the chronic cough, everything gets back to normal. Wheelchair bound, it may be because of the poor bladder control, the muscle and whatnot. Okay, and this is called overflow incontinence. So the treatment can be quite significantly different. They might need urinary catheter and all those things. Coffee, diuretics, it can trigger you to have urge incontinence. So if you have urgency, which is very excessive, until you were to have incontinence, you may want to reduce your coffee. Constipation is also another thing. So lifestyle modification, food and diet management, enough fibers, treat the constipation, reduce caffeine, tea, coffee, Chinese tea, any tea, it can trigger urgency. Timely voiding is that, if, for example, a patient has rheumatoid, OA, osteoarthritis of the knee, they cannot get to the toilet on time. So I would advise them to go to the toilet every 3 to 4 hours to avoid them from, wetting themselves. Losing weight, quit smoking, and also the constipation part. Physical therapy, Kegel exercise, pelvic floor muscle training to strengthen the muscle. We have something called PTNS, pretibial nerve stimulation. We stimulate the nerve of the pretibia over here, and this will actually assist the overactive bladder symptom, which is the urgency and the frequency. Acupuncture also helps. Yeah, this is like a modern acupuncture over there. So this device actually, deliver the electric current. Over here, this is the needle, electric current. It goes up. They can feel the tingling sensation going towards their upper thigh. So we were to do this weekly for about 6 to 8 times. And, if patient is genuinely having overactive bladder urgency frequency, they could see that the nerves are less sensitive and they are able to hold their bladder longer. So the correct patient, correct treatment, most of the time it works for them, and they don't come back after that. They can come back for maintenance once a month. There's a lot of new things around. So if you're not sure, you want to know more, we can always discuss about it further with the patient. It's like a modern acupuncture basically, but it works in quite a large group number of patients. We have journals about it also. Pelvic floor, make sure that they do it correctly. If they're not sure how to do it, refer to the physiotherapy. But again, you have to tell your patient you take about 4 to 6 weeks before they were to see improvement, because Malaysian being Malaysian, we are always very impatient. We do it today, we want fast result tomorrow. So I tell my patient again and again, you must be consistent, do it at least once a day, and you'll only see improvement after 4 to 6 weeks. So you have to be patient and you have to be consistent. Drug treatment. If you have overflow because the patient have incomplete voiding, alpha blocker might help in certain cases to loosen up the pelvic floor, especially those who have very tense pelvic floor. That is for the incomplete voiding that can cause overflow. The urge incontinence for menopausal lady, topical estrogen might be beneficial. We have anticholinergic for urge incontinence or beta-3 agonist for urge incontinence. This is medicine for overactive bladder. We have the Detrositol, the Tovias, the Vesicare, the Betmiga. You can try this first, because if all this doesn't work, patients still have incontinence, you can offer them sling procedure. But again, sling procedure is where you provide support to the bladder neck. So it is for stress incontinence because the support is weak. If you were to give this to urge incontinence, it may not work very well because the problem doesn't come from the poor support. It comes from a naughty, twitchy bladder. So sling procedure, stress incontinence. That was why I was mentioning earlier on, it's important for us to know what type of incontinence is your patient suffering from. We also have colpo suspension, also for stress incontinence. It doesn't work for urge incontinence. Okay, how about urge incontinence? We heard about Botox. Well, when I told my patient, you have urge incontinence, the Betmiga, the antimuscarinic doesn't work, I would like to inject Botox to you. Then she was like, wow, I'll be looking 10 years younger. Then I said, I'm sorry to break the bubble, to burst the bubble. I actually will inject Botox into your bladder to, cause a mild spasm of the nerve in the bladder so that you can hold your urine better. Then she said, well, doctor, maybe you can inject 50 units into the bladder and 50 units to my face. So, it's a good compromise. I said, well, you need to see the aesthetic if you want to do it on your face. I will help you with your bladder. All right. So one thing about injection of Botox, similar to injecting it on the face, it doesn't last forever. It usually stays in the body for about 6 to 9 months, maximum for about a year. Then after a year, the urgency or the urge incontinence will recur. Then the patient will need to come back for repeat injection. But they don't have to worry about medicine anymore because it works most of the time. And we can increase the injection to 100 unit, 200 to 300. But most of the time, we'll start with 100 first. We have to also inform the patient that, there's risk of UTI after the procedure. And one thing about Botox is that it doesn't work immediately. If you were to inject the Botox today, sometimes it takes as long as 4 to 6 weeks before the urgency gets better. So patient have to be, you may still want to overlap patient with the antimuscarinic or Betmiga, which is the beta-3 medicine, while waiting for the Botox to work. Okay, sacral nerve stimulation is a very niche area. We do have it in Malaysia, but not many places does it. In other words, this is a pacemaker for the bladder. It reprograms the bladder. So you were to put it's an implant on, they were to implant it on the buttock, and this transducer over here goes to the S3, it stimulates the S3 nerve. It reprogram the bladder. There's a certain patient will have a device like a handphone where they have the new program for their bladder. So based on this, they will go to the toilet. So it's a timely voiding being set up in a device. This is for patients who fail all the simple treatment of urgency, like the Botox, like the medicine. And this is a permanent implant. Nowadays, we have those who which is safe for traveling. It doesn't beep at the airport, so on and so forth. The older ones, we give them a small card to bring along if they were to go through the X-ray machine at the airport, because we don't want them to be accused of having a bomb implanted into their body. Then things will get very unpleasant for the patient. Okay, augmentation cystoplasty is a major surgery where we bivalve the bladder to disconnect the nerve from one end to the other end, so the urgency become less, and we were to put bowel in between. So that is where we call it augmentation. So we put a bowel in between, so it enlarges the bladder capacity. The patient can hold urine longer, and at the same time, we disconnect the nerve from the left to the right side of the bladder. Hopefully, they do not have urgency incontinence, which is very bad to manage. Finally, if everything fails, urinary diversion, they will end up with a stoma. So I'm not really keen on the urinary diversion if the rest of the treatment can provide healing for the patient. All right, that's all for tonight.
I
We
think
have
a lot of what you say can also, of course, apply to men.
yes, but I skipped the prostate part because when we talk about men, we talk about the prostate also.
And then the other thing I want to ask you is, I think that prolapse, vaginal prolapse, or is it common in women? Is it part of the cause of UTI and also incontinence?
Okay, very good question from Dr. Betty. Let me just share my slides here. Okay, so if we were to talk about incontinence, I do not treat, if we talk about pelvic organ prolapse, most of the time, if it's very serious, I will refer to my urogynec friend. So if we have types of pelvic organ prolapse. In a normal situation, everything is in place. You can have cystocele, which is prolapse of the bladder because of the weakened vaginal wall. So you can see, so if patient is in lithotomy position, at the 12 o'clock, you will see that the bladder tends to come down. All right. And uterine prolapse is when the uterus descends into the vagina. And if it's very bad, you can actually see the whole uterus. You can see the cervix and the uterus coming out. And then rectocele is when the rectum comes out. And enterocele is when the vaginal wall as you can see over here, the small bowel herniates. So in all the situation, if you were to look at the pink arrow, it were to cause squeezing of the urethra. So that is why in this patient, I have an elderly lady that came to me about 2 weeks ago. She said, I've been having consistent, persistent urinary incontinence over the last 6 months. And then she said, I've gone to see GP, they have started me on antibiotics, treat my UTI, but it's still...
Sorry, hold on.
Hello? Yes.
Uh,
Okay. All right. So the incontinence doesn't go away. And true enough, when we were to do an examination of the pelvic floor, she have a very bad prolapse, uterine prolapse. So if you have a very bad uterine prolapse, it can cause problems such as incontinence. And the type of incontinence that this patient has is continuous incontinence. Daytime, nighttime, coughing, non-coughing, it happens all the time because it kinks the urethra. The bladder doesn't empty well. So if you have a patient who comes to you with persistent incontinence and they are elderly, menopausal, first thing first, rule out there's no pelvic organ prolapse. It can be any one of these. So, when you refer to your urogynec colleague, so this is the causes because of childbirth, age, after menopause, obesity or heavy exercise, because they tend to put stress on the pelvic floor, the support is not there as good as before. Other signs to look out for POP, they may have constipation because the rectal area might be affected. Some might tell you that it's difficult to insert tampon because the vagina is collapsing. They can have lower back pain and they just feel very uncomfortable down below. They leak urine or they said they have to push harder to pass urine. So these are the 6 signs and symptoms. So spend some time, look down there. The prolapse might just the one that needs treatment. And as you know, if it's very mild, Kegel exercise can help. You may also want to advise them to take the rich fiber diet so that avoid them from getting constipation. And we have pessary. My fellow urogynec friends or my obstetric friends are very familiar with pessary. The common one is a donut. We put that into the vagina to push up the cervix and the uterus that has fallen down. At the same time, it rearranged the anatomy so the patient is able to pass urine. So the lady that I saw about 2 weeks ago, she's 73 years old. She have 2 months history of persistent incontinence. And true enough, we put in the pessary for her. I saw her 2 days ago in my clinic. She said, no more leaking. She is so happy because she doesn't have to wear diapers anymore. So that is all that she needs because, she read online as usual. Dr. Google is very, very helpful to scare you. Dr. Google said, you need surgery. So she said, oh, I don't want surgery. I said, well, if the pessary works, there's no more leaking and it stays in place. Thank goodness over the last 2 weeks, it has stayed in place. Thank you to my gynae colleague. So I saw her, I said, no more leaking, no more problem. I will see you over the next 1 month to make sure that everything is okay. And I said, do your Kegel to avoid the prolapse to become, to at least strengthen the pelvic floor muscle. So basically that's it about pelvic organ prolapse. Yes. Any more questions or any questions from
okay, hold on.
audience? Yes, thank you, Dr. Betty. Thank
Oh,
you,
I'm
everyone.
sorry.
Yep.
Because there are some questions. Because there's some changes over the the Google form, so I am now struggling to figure it out. But we have, okay, we have people registering for the Google e-cert, so everything is settled. Let me just get back to some questions. I think here we can see Dr. Nina asks, good evening, doctors. I have a patient with recurrent UTI every year and have given fosfomycin culture done unremarkable result. What to do next? Patient
Oh,
opted to
all right.
uro. Great. How go and see Dr. Masyithah?
Well, thank you so much for the question. I've mentioned earlier that recurrent UTI is when you get UTI twice within 6 months or 3 times in a year. So based on what the question said is once every year. So that is not recurrent UTI. That is okay. That is a fairly normal for us ladies to get it once a year. But again, if you're not sure, are you, you're very concerned about your patient, you can always send her over for an ultrasound at least, or I can do a Euroflow. I will check whether she's actually emptying her bladder well, or is there anything else that needs further investigation, like a CT scan or an ultrasound. I'm more than happy to see the patient. She can come and see me either in Damansara or KPJ Klang, or any of my urology colleague will be more than happy to assist.
Yeah, but sometimes women are more comfortable seeing a woman
Yeah,
urologist.
because because I've spoken to a patient, she said she went to see a male doctor. So she told the doctor, I have something like this nagging pain, like period pain. Then I was like, and she was like, how would he actually understand period pain in the first place? To them, pain is pain. And she said, no, it's not like very, very painful, but you know lah, that heavy thing, like before you get your period. And then she said, well, that doesn't make sense to him. So I would rather see a lady doctor, because when you mention about period discomfort, before the period comes, ladies will understand that better. And we know it's not very painful, but it's painful enough to disturb you on your daily activity kind of thing.
Okay. Amy from Facebook, who's actually cardiac tech, she asked, right?
Mm-hmm.
If we have a very strong urge but stuck in the jam,
Okay.
okay, what can we do? Is coughing will make the urge go away?
And I don't think coughing will make the urge go away. It can actually worsen it, because you tend to exert your abdominal muscle.
Right.
What I usually tell my patient is that if you have very strong pelvic floor, you do your Kegel religiously. Kegel can be done at an early age. The moment you had delivery, even when you're early 30s, you can start doing Kegel, because like going to the gym, you don't have to be overweight to go to the gym. So you don't have to have incontinence to do Kegel. If you have very strong pelvic floor, you contract your pelvic floor, most of the time the urge will go away. So, but if you fail that miserable time, you wet yourself, then you may have UTI at that moment. Or one thing that I usually tell most of my patients, if you know that you are the kind of person who may develop urge incontinence, try not to drink too much when you're driving, knowing that you're going to get stuck in the jam. Try to avoid caffeine on your way back from work. At least you can get to the toilet on time when you reach home. But first thing first, you can start with Kegel. Most of the time, good Kegel, good muscle support, you can not leak in the car, and the sensation will gradually get lesser and you are okay.
Okay, Dr. Ruba asked, for cystitis, is oral or IV antibiotic better? And
Okay.
or cyst would be better treatment. I'm not sure where's cyst.
Okay. Usually for cystitis, if it's a young lady, low risk, first time, I can always start with oral first, except that if she has fever, pain is excruciating, I will admit her. But some ladies, they have cystitis, but they are still okay, and oral medicine is adequate. But if it's elderly, you think there's more than just a cystitis, she have poorly controlled sugar at the same time, then you may want to admit patient, put in a urinary catheter, drain the bladder well, and start on intravenous antibiotics, do a urine culture, especially if it's a recurrent cystitis, they may have resistant bacteria that is not suitable for oral antibiotics. There's a question here from Radhika. Yes, good evening, Radhika. So what is the first line antibiotics recommend in primary care setting? All right, I usually Well, in a primary care setting, we have a few. Cephalosporin is one of it. Cefuroxime, ciprofloxacin, augmentin. So, just make sure that patient doesn't have any allergy. And even phosphomycin monurol is also known to be very good for UTI if it's not very severe. Monurol is good because they only take it one dose. If you were to look at the leaflet, it's 3 grams of monurol or phosphomycin is a single dose medicine. So, and most bacteria like E. coli and Klebsiella responds well to monurol phosphomycin. One thing about phosphomycin is that you need to tell the patient how to take it correctly. On the night they were to take the medicine, 2 hours before bedtime, do not drink too much, stop drinking, pass urine, only mix the medicine with about 50 to 70 mils of room temperature plain water. They drink the medicine, then they go to bed. The best is not to pee for 6 hours, which means that if they were to sleep at 11, they only pee the next morning. If they have urgency, what I usually tell the patient is that it may not work very well because you are able to hold your bladder. But if the urgency is related to UTI, treat the UTI partially first, maybe the first 3 days until the urgency, the frequency is less. Take the monurol and then continue your antibiotics for 7 days. That is also one regime that I usually tell my patient that it works. And again, urine culture will be very helpful to know that you are treating the patient correctly. Yep.
Since we are
Alright.
at the topic of antibiotic, what do you use for prophylaxis?
Okay, prophylaxis, usually I use nitrofurantoin. Previously, we have 50 milligrams of nitro, but we don't have that currently in most places. 100 milligrams is okay. We were to use that for those who have problems with the sexual intercourse causing the UTI. It works, nitro 100 milligrams after sexual intercourse or before sexual intercourse. It depends which one works well for the patient. They can try and error kind of thing because it's difficult to say. One may need it before as a prophylaxis, one will prefer to take it after because that works better for her. All right. Okay, yeah, Nina asked here. This is the phosphomycin. All right. Okay, next we have that. And contraindication for PTNS, IHD pacemaker. Hi Rose, thank you for your question. So far, there's no contraindication because it's just a local current. It's just at the leg area. It doesn't really circulate up to the pacemaker. I have not I've not run into any leaflet, but again, of course, it will be good for you to ask the pacemaker because the patient might have a different setting, a different type of pacemaker, just to be safe. But so far, there's no contraindication. IHD, even though they're on aspirin or whatnot, I do not ask them to stop the aspirin or Flavix before putting in that tiny needle because the needle is very tiny. It's just like a normal acupuncture needle. Right, cystitis, oral IV, we've answered that. Okay, first line. Okay, lactobacillus. Okay, thank you, Timothy, for your question about the probiotics. Yes, I do recommend patients take probiotic, especially in, if they have recurrent UTI, they can take the probiotics for the first 3 months, just to build up the good bacteria in the bladder so that there's no space for the bad bacteria to grow. Most of the time, it's a better option because it's supplement and it's not antibiotics per se. It's recommended in the guideline, and if you were to look at the inflammatory bladder guideline, is also mentioned as using lactobacillus probiotic for recurrent UTI prevention. I usually treat the UTI first, then I will ask the patient to be on lactobacillus probiotic for about 3 months.
How does
All
it
right,
work?
so sorry.
How does lactobacillus probiotics work?
Okay, so when I looked through it, they said, if you are postmenopausal, the pH of the area down below the perineum is not as what it was before. It's drier than before. So the good bacteria, which is the flora, the normal flora down there, is not as abundant as before. So by taking the probiotic, it replenish the flora. So that can avoid, because when most ladies are younger, they don't tend to get UTI very often. But then when they postmenopausal, they tend to get UTI quite often. So it's because of the probiotic, the normal flora is reduced. At the same time, if the patient has been on, shopping antibiotics, they have been taking antibiotics for so many times and they did not hit the right bacteria because they did not do a urine culture, they need to replenish the normal flora again. All right, so Nazira has a question here. Elderly women, frail, urge incontinence, what is preferred medical management? Well, I usually try the oral one first. You can first, of course, urge incontinence can also be managed with Kegel exercise. If they are still okay, you can send them to the physiotherapist. They can learn how to do Kegel effectively. You can use desmopressin or Betmiga. However, Betmiga is contraindicated in some cardiac patients, so you may want to check with the cardiologist on what medicine is the patient on. So you can do just beta 3, or you can do combination of beta 3 and the adrenergic like the Vesicare, the Trucitol. The contraindication is usually for close angle glaucoma. That is one thing that you need to ask patient. And dry eyes, dry mouth is a common side effect, but Betmiga, which is a beta 3, has less side effect because it's more targeted for the bladder. Right, persistent hematuria. Okay, so thank you, Dr. Sureka, for the question for the persistent hematuria. If it's just very low and is persistently 10 or below, and patient is low risk, non-smoker, no family history, I will just continue monitoring. But the moment, usually I were to do like either 3 monthly or 6 monthly urinalysis, the moment the number tends to be increasing, I will advise the patient to have cystoscopy, because as we know, when we are elder, the risk of cancer is higher. So I may want to do cystoscopy in this group of patient. But if some patient comes to me and said, for the last 10 years, it has been a single figure of RBC and all the renal profile, you can do a CT IVU just to cover all bases. If the CT IVU is normal and the hematuria is 5 to 10, I will just continue monitoring, except that, she suddenly developed becoming high risk. For example, she developed cancer elsewhere, then I will recommend her to do a cystoscopy. Or she suddenly developed gross hematuria, then yes, we'll do the cystoscopy for her. All right, psoriasis would be treatable or follow. Okay, I am not so familiar with psoriasis. Ruba, I'm sorry. Is there a different name for psoriasis?
Okay,
Mhm.
there's a question. Does cranberry juice really prevent UTI?
Okay, if you were to look at EAU guideline, they say it doesn't. This is because cranberry juice is juice, but it's not the extract. But there is a probiotic in the market now, which is a combination of probiotic plus the extract of cranberry. Studies have shown that when it's the extract, which is a very high concentration of cranberry, offhand, I cannot remember the name of the substance in the cranberry. It does help with combination of the probiotic. But if by just drinking cranberry every day as drinking, it doesn't really help, and that has been proven in the EAU guideline. There is a statement in the EAU mentioning that cranberry is not advisable as a method of prevention of UTI or treatment of UTI.
Okay, last question. Vinvi asked, in
Mhm.
terms of dose-wise for urge incontinence, what's the initial dose and then do we increase the dose?
Okay. Usually I will start, if I were to start with Betmiga, is always 50 milligrams. That is the maximum dosage for Betmiga. I usually give them for 2 weeks first or 1 month. After that, I will reassess the patient. If she said that her urge is slightly less, only minimally control with Betmiga 50 milligrams, I will add one of the antimuscarinic, like the Trucitol or Vesicare, or I usually go for Vesicare because Vesicare comes in 2 doses. I will ask her to add Vesicare 5 milligrams, try it for another 1 month, or try Vesicare 10 milligrams. But the thing about Vesicare is that it may cause difficulty. If you have Vesicare plus Betmiga, they may have hesitancy, as in difficulty to initiate urination, because it causes the contractility of the bladder to be less. So I would tell the patient, you try 10 first. If your urge is well controlled, but you have difficulty initiating urination, you may want to reduce it to 5 milligrams. So if they're okay with that combination, I would tell them to continue for 6 months, because the literature has shown in 70% of patients, when they stop after 6 months, they are treated. They do not have to go back on the medicine. But there is still 30% of patients who needs to go back to the medicine either every day or they can take alternately. So that is my usual interval that I do. Okay, chiasis. Okay, this painful cystitis, hiasis is something like intravesical treatment. We have hiasis, we have Instillin, we have cystistat. So it is believed that I think hiasis have hyaluronic acid component. So what the literature talk about cystitis, especially painful ones, interstitial cystitis, the protective barrier in the lining of the bladder has been eroded. So the potassium, the urea penetrate into the wall, causing frequency and also bladder pain. So what this intravesical treatment does is that it seals back these holes in the bladder. So it recoats the bladder. So for this kind of medicine is given every week, intravesical, put in a urinary, ask the patient to pass urine, put in a urinary catheter, inject the medicine weekly for 4 weeks, and then monthly for 2 months. So the whole course is about 6 times for the patient. If they are okay, they can come back for maintenance once in every 3 months. So it has been written in literature for interstitial cystitis or painful bladder syndrome that by recoating the bladder, the pain will gradually go away because the substance in the urine, like the potassium and the urea, doesn't cross the bladder wall anymore. So it is mentioned in the guideline for the Painful Bladder Society, GIBS. Yes.
Okay,
I
there's
guess
one
that's
last
all the
question.
question. Yes.
Sarah Bhavani from Facebook asked, the simple kidney cyst cause frequent UTI?
Simple cyst. Okay, if you talk about cyst, when you do CT renal 4-phase, they will come with classification, which is Bosniak. You have Bosniak 1, 2, 2F, 3, 4, and 5. Simple is usually 1 and 2. So no, it is not related to any urinary symptoms. Very rare. It's not. If the patient have UTI, it's not because of the cyst. Cyst is just like a growth on the skin, but this one grows on the bladder. The cyst can also happen in the liver anyway, so it's not related to UTI, and it doesn't cause hematuria, except that it's a Bosniak 4 and 5, which is related to renal cell carcinoma.
Okay. Thank you so much. And I have one question. How
Yes,
come
Dr.
you became
Betty.
a urologist?
Because there's not many.
Betty will do. Just keep call me Betty will do.
Okay,
I
Betty,
just
there's
want
not
to
many.
know. Yeah.
Yeah, there's not many female urologists around. So first thing first, when I was a master's student, I went to a urology conference. So I went to the hall. It was just, I'm trying to find a friend to sit with, but there's no female around except for nurses. Because every time I were to bump into them, at common places like toilets or surau, when I ask them, doktor dekat mana? Oh, saya nurses. Saya nurse ni nurse. So I was like, tak ada female perempuan ke? And then they said ada but not many. So when I joined at that time, there was only Miss Susan, who is a very senior consultant at that time in HKL, and Dr. Pongodi was a trainee at that time. So I told myself I would like to be one of them, because my nurses usually come to me and said, when we have hematuria, we want to do cystoscopy, or when we have UTI, we want to talk about the pain and everything. Men don't really want to listen to us ladies, because to them we are just nagging. So they say it will be very nice to have a lady doctor which understand us better. So that is one reason why I decided to do urology. And not just that, urology, you have many things, many kind of surgery. You have open surgery, you have laparoscopy, you have robotic, you have laser surgery, scopes and everything. So there's variety of things. So it makes things more colorful every day going to work, rather than doing this similar thing day in and day out. So that's one of the reasons. Well, one of the few reasons. Never regret being a urologist, and it's always nice to see happy faces. You clear the stones, they're happy. They don't come back and see you. They have no more bladder pain. They're happy. So that's the reason, Betty.
Yeah, you're the first female urologist. I've been in this industry for so long. You're the first female urologist that I know.
Thank you so much. So there's
Yeah.
more to come.
Proud of
Yeah. Yes, because we kick off and everyone seems that it's nice to have ladies, especially if you have stones and all the surgery comes from down below, and in certain places it's done on the spinal. You are awake in lithotomy and man is sitting in between the legs trying to remove your stone. That's not a very pleasant feeling. So if you have a lady doctor, it's more comfortable for the patients. So I'm more than happy to see patients. I do treat adults, men also. So women, of course. So I'm happy to see anyone who have any urology problems. So you can refer them to me, Or, since we have gone through a few basic topics today, you can always treat the patient first. And if you have difficulty helping your patient, I'm more than happy to help in any way I can. Thank you
Okay,
so much, Christina.
everybody. Just a reminder that next week we have 2 webinars, one on Monday and one on Wednesday. And on Monday
Wow.
will be very interesting is how to it's actually a doctor who has not who left clinical medicine to become to work in pharma company, and now he's a celebrity with LinkedIn and influencer there. So his doctor asked her. So he's going to teach us how to cope with the very competitive in this very competitive world. Yeah. Thank you so much. See you on Monday then. And then thanks so much, Masyithah. Maybe
Thank
we could-
you.
yeah, it was a very good session. I was
Thank you, Betty. Thank
yeah.
you,